Good evening, everybody, and welcome to this monthly MedEClasses postgraduate lecture series in which we are going to talk about a very important topic of hypokalemia. This lecture series, as we've discussed earlier, is an event which we organize monthly, and we propose to have 36 such sessions covering the entirety of postgraduate relevant pediatric endocrinology. So we have been running on electrolytes for these last few sessions. We're on hyponatremia, hypernatremia, and today we talk about hypokalemia. Now, hypokalemia is very common in terms of pediatric practice, but Dr. Manoj, what do you think are the major causes? So today I'm joined by Dr. Manoj Agarwal and Dr. Vibha Yadav, who are fellows in pediatric endocrinology, who will be part of this program. So Dr. Manoj, what do you think in terms of from a pediatrician's perspective, how common are endocrine causes of hypokalemia?
So if we talk about the pediatric perspective, then the diarrhea and vomiting is major cause of the hypokalemia. So it is a normal in the for the pediatric, but we have to keep our eye and ear open to not miss the sinister pathology like RAS excess or tubulopathy or the Bartter or Jitterman syndrome, because this can cause the persistent and the chronic hypokalemia. So identifying etiology is a very major cause in this particular concern.
So, Dr. Vibha, what do you think are the pointers when somebody should start thinking that, okay, this is not a simple cause of hypokalemia, we are thinking of some form of a endocrine cause of hypokalemia?
Like when any patient comes with like a failure to thrive, not gaining weight, and having like malnutrition and having multiple fractures, like in the case of RTA, it could be the cause of one of the hypokalemia. And we should not miss it because it would lead to very life-threatening complications of metabolic acidosis. And another another symptoms could be like paralytic ileus or having this could be many problems.
What would you look at in terms of hemodynamic status, which will tell you the likelihood of an endocrine cause? Which parameter you will look at?
So for the hypokalemia, there will be for the ECG you are talking about?
No. So I'm talking about what will be the pointer that this is an endocrine cause. So if this thing is high, you start thinking this is an endocrine.
Sir. Basically, BP. We will look for the BP. If it is high, then definitely there is the RAS axis. It is involved here. And
yes. So as Dr. Manoj and Dr. Vibha have said that the hypokalemia is very common in pediatric practice. We talked about hyponatremia. It is also common, but there are much more endocrine contribution, particularly of SIADH. Hypernatremia, which we discussed in the last session, is usually because of dehydration, or a chronic hypernatremia would basically is equivalent to diabetes insipidus. This is what we discussed. But when we talk about hypokalemia, there are many more acute causes. You may have a gastrointestinal loss, you may have diuretic cues, you may have urinary loss, which will be more common. But if you have chronic hypokalemia with hypertension, along with that severe failure to thrive in polyuria, you start thinking of tubulopathies and endocrine causes which may become relevant from that perspective. So we'll be starting the session. We'll talk initially about pathophysiology. Then Dr. Manoj will talk about etiology, followed by assessment and management by me. And Dr. Vibha has collated a number of interesting questions which are relevant from postgraduate perspective, which can come from that perspective. So as we have discussed, hypokalemia is a common finding, but often it becomes like a diagnostic challenge, which is there in that perspective. So one needs to be aware and open to the various possibilities which are there. So we had this 2-year-old boy who presented with failure to thrive and had a significant failure to thrive in the form of weight of only 8 kilograms and compromised height with hypokalemia. Now, based upon the workup, and we'll discuss subsequently as to how blood gas becomes very important in here in terms of evaluation, the patient had alkalosis, which was quite significant, and further workup showed a normal blood pressure. Along with that, a hypocalciuric situation and a low magnesium. So we had a child who has hypomagnesemia with failure to thrive with hypocalciuria. The most common diagnosis people make is that of Jitterman syndrome. But the challenge in the evaluation of hypokalemia is not to rush towards unusual causes, because common causes are more important. So what we should consider here was to look at malnutrition. So when we looked at the fractional excretion of magnesium, which was low, it suggested that this was primarily a cause of malnutrition causing hypokalemia rather than a tubulopathy. So we need to have a comprehensive assessment with regards to the evaluation before we reach to a particular cause, because that cause deserves a specific treatment in that perspective. So as discussed, we'll touch base about pathophysiology, followed by criteria and etiology, management, and then we'll go forward from that perspective. All of you can go and have a look at our website, learning.growthsociety.in, which has got validated modules with regards to different aspects of pediatric endocrinology. We have got our e-learning portal on YouTube, where now there are a large number of videos, and you can also access our courses, which provide validated tools for assessment and evaluation. We have specific courses in the form of fellowship in pediatric endocrinology and pediatric endocrinology for postgraduates, cater to specific needs of people at different levels of careers. We do conduct 3 programs on a regular basis in the form of a pediatric endocrine grand round, a pediatric endocrine focus discussion, and this PG lecture series, which cover entirety, and these are available routinely on Zoom and YouTube. All the recordings are there. There are 2 publications which are available through our website, as well as the Kindle book reader and a mobile application, which helps in terms of assessment and diagnosis. So starting about potassium homeostasis, we need to understand that there are 3 major components which regulate the potassium status. One, of course, is the intestinal absorption and the renal excretion. But the third major factor is also the intracellular component. So we need to understand that as against sodium, when we talked about hyponatremia and hypernatremia, which is mainly a extracellular ion, potassium has got a huge resource which is there inside. So fluxes which happen between the intracellular and the extracellular compartment do have a significant role in acute changes in terms of potassium. So if we talk in a very simplistic manner, the acute changes in potassium would usually be because of an intracellular shift. So we have some mechanism by which potassium goes into the cell that will cause a severe hypokalemia in the form of a channelopathy, in the form of insulin excess, in the form of metabolic alkalosis. Chronic hypokalemia would require a decreased intake or a gastrointestinal loss, but most importantly, urinary loss of potassium. One thing to remember is that unless we have increased urinary loss, the body will be able to compensate the potassium level. So if you have hypokalemia, it means that there is an increased urinary loss of potassium, and that is largely driven by the renin, angiotensin, aldosterone system. So as we discussed in hyponatremia, any patient who has got a chronic hyponatremia has an excess of AVP, whether it is appropriate or inappropriate. Any patient with chronic hypokalemia will have an excess of the renin, angiotensin, aldosterone system, whether it is primary, which is a pathological cause, or secondary, a compensation to hypokalemia. So RAS excess is fundamental to hypokalemia, and this is something which is very, very important to understand in that perspective. Now, we have discussed clearly that potassium is largely an intracellular ion. There is a 40 times more concentration within the cell as against the extracellular compartment. And there is an elaborate mechanism. A lot of energy is spent by the body to ensure that potassium is in the cell and sodium stays outside. And that is done through the sodium-potassium ATPase, which requires a lot of ATP, exchanging sodium outside and getting potassium inside. Agents which increase the sodium-potassium ATPase activity, namely insulin, beta agonists, can cause sudden onset hypokalemia. And insulin is particularly important in the setting of treatment of diabetic ketoacidosis. Now, we all know that in DKA, there is a significant amount of potassium loss to the tune of 4 to 6 millimoles per kg. But most of this loss is compensated by the efflux of potassium from the cell outside because of insulin deficiency, acidosis, and other parameters. Now, as soon as you give insulin, as soon as you correct acidosis, this potassium goes into the cells, causing a significant hypokalemia. Similarly, in malnourished individuals who have a sudden recovery, or we are doing too much overfeeding, will result in an increased insulin release, which will cause potassium to go inside, causing hypokalemia of refeeding. So insulin plays an important role in the cellular efflux mechanism of this regards. The other intracellular ions include magnesium and phosphorus. And one key principle which we need to understand is that if you have deficiency of one intracellular ion, there is a deficiency of the other as well. So if you have hypomagnesemia, you will also have hypophosphatemia and hypokalemia. Similarly, if you have hypokalemia, you will also have hypomagnesemia and hypophosphatemia. So in simple terms, if you have chronic hypokalemia, like if you have chronic hypocalcemia, do go and measure magnesium level as we showed in the first case in that perspective, and that becomes important. Now, we need to understand a bit, as we talked about, there are three major components: the cellular exchange, the intestine, and the kidneys. So within the intestine, we need to understand that potassium is basically secreted a large amount in the lower secretion, and where you also have bicarbonate. So if you have excessive loss because of diarrhea or lower gastrointestinal tract, you will have acidosis. While if you're having vomiting, you will be losing a lot of acid, which will result in hypokalemic alkalosis. So the basic difference between hypokalemia because of the upper GI loss is that it is associated with alkalosis, while if you have a lower gastrointestinal loss, you will have acidosis. Now, this relation of potassium and proton is also very important. We need to understand that there is a competition between potassium and proton, both for going inside the cell as well as being lost in the urine. So if you have hypokalemia, generally there will be alkalosis as a normal response, because if you have hypokalemia, the body will be losing a lot of proton. It will like to conserve potassium, and therefore in that conservation process, it will lose proton. And this is what we'll discuss about when we talk about renal homeostasis. So generally speaking, if somebody has hypokalemia, they will have alkalosis. If somebody has hypokalemia with acidosis, there are very limited causes, broadly two causes: lower gastrointestinal loss or renal tubular acidosis. So the most important investigation to look at in a child who has chronic hypokalemia is the blood gas, because it gives you the diagnosis right away in that perspective. Now, whether you have a vomiting or whether you have a diarrhea, your volume will come down, and this volume is going to trigger the renin, angiotensin, aldosterone system, which will then cause potassium loss and sustain the level of hypokalemia. If you do not have dehydration or the RAS axis is not activated, you would not anticipate to have this persistent hypokalemia. So as discussed initially, to have a sustained hypokalemia, you require a RAS excess, whether it is a primary phenomena or a secondary phenomena in that regards. Now, coming on to the third most important aspect of potassium handling, that's the renal system. So we all know that potassium is freely filtered in the glomeruli, and it's all reabsorbed in the proximal tubule. So whatever potassium we get actually comes from the collecting duct, and this is an important concept to understand, and this happens in exchange to sodium. So the epithelial sodium chloride channel, which basically is there in the collecting duct, will cause a migration of sodium or an efflux of sodium along with chloride. The passage of sodium is quick, chloride goes a bit slowly. So this creates an electronegative environment in the lumen, and this will then drag all the positive ions which are there to be lost in the urine. So if you have increased sodium delivery in the distal region, in the form of increased salt intake, in the form of diuretics, or if you have increased RAS activity or absorption or the activity of the epithelial sodium chloride channel, you would be absorbing more sodium, you will be losing potassium. So any condition in which you're taking too much salt, there is a RAS axis, there is an epithelial sodium chloride channel activity, which is more, this will be associated with significant hypokalemia. Now, other positive ions which will also be lost will include the proton, and along with that, you will have a loss of ammonia in that perspective. So if you talk in that perspective, when you're losing potassium, you're losing proton as well. So there's an association of hypokalemia and metabolic alkalosis in that regards. So if somebody is having loop diuretic or osmotic diuretics, the sodium concentration in the distal area of the tubule, the collecting duct, becomes more, and you will have more sodium loss, resulting in a compensatory hypokalemia in that setting, and this becomes relevant in that regards. Now, the whole process is largely regulated by the renin, angiotensin, aldosterone system. So we all know that the kidneys, the JG cells are particularly based upon the potassium level of hyperkalemia and hypovolemia secrete renin, which converts angiotensinogen to angiotensin 1, which is converted peripherally largely in the lungs using the angiotensin converting enzyme to angiotensin 2, which then stimulates aldosterone production. So if somebody has hyperkalemia or hypovolemia, the aldosterone levels will go up and this will cause potassium loss. So hypovolemia, therefore, is an important stimulus of potassium loss causing hypokalemia in that scenario. So within these three organ models of a cellular shift, gastrointestinal loss, and the renal loss, we can now consider the pathophysiology or etiology of hypokalemia. If somebody is taking less amount of potassium, it's very unlikely to develop hypokalemia. But if there is associated hypomagnesemia, and as I said, if you have hypomagnesemia, the renin, angiotensin, aldosterone system will go up, and any intracellular loss of one ion will cause loss of others. It will cause significant hypokalemia in that scenario. Intracellular shift will be relevant during insulin treatment or alkalosis, the use of beta agonists, and particularly intramuscular chloroquine, and that could be a lethal form in that perspective. And of course, channelopathy is in which suddenly the channels open up and the potassium goes out in that perspective. Intestinal loss can happen with the setting of diarrhea, where you have associated acidosis, or vomiting, where you have associated alkalosis in that scenario. NG aspiration will also behave like upper tract loss with hypokalemic alkalosis. The renal loss will be, the important cause will include metabolic alkalosis. So hypokalemia causes alkalosis, alkalosis causes hypokalemia. Tubulopathies like Bartter and Gentleman syndrome, loop diuretics, and of course, excess of the renin, angiotensin, aldosterone system, hyperrenism, renal artery stenosis, aldosterone producing tumor, epithelial sodium chloride channel defect in the form of Liddle syndrome, they will all cause abnormality. So from an etiological perspective, hypokalemia can be because of cellular shift. These are acute causes, insulin beta agonist, periodic paralysis, and add risperidone in that perspective, or an extrarenal cause in which you have got a urinary potassium which is low, which includes a GI tract abnormalities like vomiting or NG aspiration, or really cystic fibrosis. Or finally, the most common cause ultimately is a urinary loss where the urinary potassium is high. This could be a RAS-dependent process with hypertension, including aldosteronism, in which aldosterone levels will be high, Liddle syndrome, which is basically epithelial sodium chloride channel activation, or CH variants in which you have got increased apparent mineralocorticoid activity. These are associated with low levels of aldosterone. Finally, you may have a scenario which is RAS independent, which includes tubulopathy, which is associated with alkalosis, and renal tubular acidosis, which is associated with acidosis. So if we talk about hypokalemia, we need to first understand whether there is a cellular shift or not. If the shift is not there, look at urinary potassium. If it's low, we're talking about gastrointestinal or extrarenal loss. If there's a urinary loss, if there is hypertension, we are talking about a RAS-dependent causes. If there is no hypertension, do a blood gas. Blood gas shows you alkalosis, it's tubulopathy. Acidosis will mean renal tubular acidosis. So most important investigations in anybody with hypokalemia, and this I'll connect later on, include the blood gas and the urinary potassium and the measurement of blood pressure. These three will give you a classical diagnosis at that point of time.